Thank you very much for attending. Welcome to our live Global Cervix Cancer Tumor Board. To all participants and viewers from around the world, a special thanks to the doctors who will be presenting our cases this morning. Dr. Cecilia Espelta from Salto, Uruguay. Dr. Mayra Pereira is having some technical problems, so we may present her case for her. She's from Buenos Aires, Argentina. And Dr. Zaida Moranti from Lima, Peru. And a special welcome and thanks to our panelists from MGH and around the US. I'd like to emphasize our usual housekeeping rules. For first-time attendees, please keep your microphones on mute unless you are speaking. Everybody keep your microphone on mute all the time. Thank you very much. It's very quiet now, so thank you. And as a reminder, the PowerPoint cases of today's meeting and the YouTube recording of the YouTube video of the panel discussion will be recorded and archived online, and so you'll be able to watch that after the tumor board if you need to, or if any of your colleagues would like to. And with that introduction, can we please get started? I want to call on Dr. Cecilia Espelta from Salto, Uruguay, to be the first person to present the case, please. Cecilia, can you hear us?
Yes, we can hear you.
Thank you. When you're ready, and we're showing the slide in a minute, you just wait for a second. There's our panelists. Okay. And there's a good-looking picture of Dr. Cecilia Espelta from Uruguay. Cecilia, please go ahead.
Okay. The case we are presenting today is a 38-year-old woman with one pregnancy 15 years ago. She's a light smoker with no previous pap test. And in the first quarter of 2015, she presented with vaginal discharge, postcoital bleeding, and her physical exam, pelvic exam, showed at the speculoscopy there was a bleeding exophytic lesion that was overinfected. And there was also shown a cervical induration with no clinical, vaginal, or parameter involvement. So the biopsy showed an infiltrating, moderately differentiated squamous cell carcinoma of the cervix, and the body CT showed no metastasis. So we performed a surgery, and it was a hysterectomy plus bilateral annexectomy plus lymph node dissection. And the pathology showed an invasive keratinizing large cell poorly differentiated carcinoma of the cervix, with lymphovascular invasion, no parametrial vaginal or ovarian involvement, with negative margin, and there was one lymph node with tumor in 19 examines, and that corresponded to a left iliac node. So the surgical stage of this tumor was stage 3B, and in the second quarter of 2015, we performed adjuvant chemoradiation therapy with radiotherapy in pelvis and scission implant, and cisplatin concurrent during radiotherapy. In the third quartile of 2015, we did a post-treatment MRI that showed a lateral aortic lymph node from left vena vein to left common iliac artery, with no signs of pelvic recurrence. So the questions for discussion are: what is the optimal systemic treatment option?
Can we just do the questions one at a time and discuss them one at a time, please?
Okay. So the first one would be: what is the optimal systemic treatment option for this patient?
Should we read out all the questions? What do you prefer, guys?
Why don't we stop the case and just sort of see? So, in terms of the extent of disease, was the nodal involvement detected by CT scan?
No. Previously, I mean, first of all, we did a CT, and then we operated on the patient. And that CT didn't show any lymph nodes.
Okay. And in terms of the size of the lesion, I know it says it was super infected, but any idea of what the lesion size was?
We don't have that in the pelvic exam. It didn't say, but it was clinically, it didn't infiltrate parametrium.
So in terms of the stage, again, I'm not sure I understand why you're calling her surgical stage 3B.
Because in the pathologic review, it said there was one lymph node in the iliac node.
Yeah. So that's just an interesting point that the Commission on Cancer, the staging group for AJCC, has recognized that it's not consistent with FIGO staging right now. That nodal involvement is not in the FIGO staging, but it is in the AJCC staging. We're trying to reconcile that with FIGO, but generally speaking, with FIGO staging, we wouldn't consider the nodes on FIGO. So I'm not sure. It sounds to me like she was a stage 1 with positive nodes. Whether that would have impacted treatment in post-surgery, probably not, but it is a problem between the staging systems.
And just for everyone's education, the staging is done clinically, radiologically?
That's actually clinical, and cervix is very funny because they don't allow extensive imaging. It's really a clinical stage. You want to talk about, it's like cysto.
Well, you can do a cysto, you can do a proctor, you can do an X-ray, you can do you can examine under anesthesia, you can do an IVP, but that's about it.
Yeah, you can't do extensive radiographic staging, and it's actually a point that AJCC has made to FIGO that it's actually the only cancer where we don't allow radiographic imaging. We allow CT scans for ovary, uterus, we allow for brain, lung, breast, but for some reason in cervix it's considered in poor, resource-poor countries as not appropriate, and I actually would like to challenge that. But having said that, FIGO staging is clinical, and CT imaging of nodes is not used, and nodal involvement is not actually considered in FIGO.
So are you happy with this being called stage 3 by FIGO or by AJCC?
I would actually clarify that as AJCC P 3B.
Right, which I think the thing is, though, Don, that it's going to be something that has to be resolved because both the clinical and the surgical staging have important implications for management, and so there needs to be some kind of classification that reports both.
Yep, I totally agree. And hopefully the AJCC is going to put out their next staging guidelines in 2015. I actually was fortunate to be one of the members for the gynecologic group who's doing the AJC staging, and we're taking that back to FIGO that they need to incorporate nodes.
But are you suggesting to me that today this patient may be treated quite differently with one or the other staging, even though she's not...
With a stage 1, if it's not a bulky tumor, we probably would have offered her surgery. But if this was a bulky tumor, we would have, done a CT, maybe biopsied some nodes, and we would not have performed surgery. We would have done definitive chemoradiation if it was a locally advanced tumor. In this case, it's, again, I'm concentrating on if it was super infected, it's likely it would look like a larger tumor than it probably was, and the question of did you treat it for its super infection for a couple of weeks and then reassess for size, or did she go directly to surgery for local indications, which is perfectly appropriate, but that would have been the difference.
Okay. So anybody want to have a stab at whether systemic options are appropriate and what systemic option would be chosen?
Well, I just want to make one more comment that I think it's interesting in this case. That she had a positive lymph node and she had radiation to the pelvis only. In some situations, at least here, I'm curious to see what they do at MD Anderson, but here we will treat also the parotid lymph nodes with radiation. And in this case, she was not treated to the parotid nodes.
Anuja, do you want to comment on the treatment of the para-aortic nodes with radiation?
Yes, sir.
Sorry, somebody's got their microphone on. Can everybody turn their microphone off, please? In Argentina, the microphone is on. Sorry.
Sorry. So, wait, Kathleen's going to ask a question, and then I'm going to comment on the radiation therapy part. But go ahead, Kathleen.
So one question is whether intra-op the lymph node was noted to be positive or abnormal. Because when we operate and come across a grossly positive pelvic lymph node, we actually abort the hysterectomy. And at a minimum, we usually sample the parotid lymph nodes if we're already in the, in surgery, to better tailor the fields. So that was just a question of intraoperatively, did you notice that it was enlarged?
Cecilia, do you want to try and answer that question?
No, it was shown only in the pathology.
Only in pathology, okay.
Yes.
Marcela, do you want to add to that?
Yeah, I mean, I think I agree with Kathleen. Certainly, that's the way that I would manage this patient. If there's recognition of intraoperatively, in fact, I started the radical hysterectomy with a pelvic node dissection because it allows me to open up the spaces, and then if one of the nodes looks suspicious, I'll send it for frozen, and if it's positive, I usually may carry a higher nodal dissection just to help delineate the radiation field, but I probably would not proceed with the radical hysterectomy. I think it's a little controversial. I think some people would proceed, and some of my partners here would go ahead and complete the hysterectomy. But the problem with that is that right off the gate, if you have a positive lymph node intraoperatively and you do a radical hysterectomy, you know that that patient is going to require adjuvant chemoradiation therapy. And so now you've subjected that patient to a radical surgery followed by essentially chemoradiation therapy. So it's very aggressive treatment, and that's when you end up having a slightly higher risk of fistula formation. Certainly some surgical complications are higher when you radiate a radically dissected field. So I agree with Kathleen. And in the presence of intraoperative lymph node metastases, I usually abort the surgery.
Okay.
Just like for the sake of argument with Marcella and Kathleen, I'd like to just observe that the data we have about the morbidity of radical surgery and of radical radiotherapy with chemo are actually pretty outdated. They're pretty old, and so I think that it'd be very important. I guess I've said this here before, but I think particularly in a network with our Latin American colleagues where there's high volumes, I think it's going to be important to continue to look at what the morbidities of multimodality therapy are, because we don't truly know with minimally invasive surgery or with IMRT what the morbidity of combined modality therapy is.
Well, I think Anuja will agree with me that we don't really know what the right chemotherapy is.
And so actually, just comments. One, at MD Anderson, we would have probably just treated the pelvis. You got 19 nodes, and only one was positive. And we don't know if it was microscopically positive or not, but we would have probably treated just the pelvis and observed the parotix. I have to agree with the fact, do we really know if surgery is necessary or not in these cases, and whether it is detrimental. And I think we are moving a little bit, even Dr. Eiffel is moving a little bit further away and say maybe you shouldn't abort the surgery if there's only one positive node, and whether you should go ahead and complete it as long as you know you have negative margins. I think the vaginal toxicity of definitive chemo RT is probably higher than if you did it post-operatively, and there are other benefits. So there is a debate. And actually some people, I'm going to be very, very controversial, some people that Don and I know very well would even debate whether a one microscopically positive node out of 19 really deserves to have radiation therapy. In Japan, they would not even radiate this person. Japan, Korea, the patient would get systemic chemotherapy. Standard treatment in the United States is to do chemoradiation. But there is a lot of debate on whether radiation at all helps with only one microscopically positive node.
And Anuja, what chemotherapy are you guys using in such a case like this?
Well, we're still using weekly cisplatin, but again, this is a case that we have the protocol RTOG 0724 open, and it is a randomized trial looking at concurrent chemoradiation versus concurrent chemoradiation followed by carboplatin and Taxol. So it's moving from the Peter study that showed that patients who got adjuvant chemotherapy actually did better than the patients who just got chemoradiation. So that trial is looking to see if adjuvant chemotherapy would be beneficial in patients who are node positive. Again, this patient would have been a low risk because she only had one positive node, but she would have been definitely eligible for that trial.
Can somebody summarize this for me? What's the definitive treatment? What's the definitive modality of treatment here?
Well, so I think I can speak for these guys, that someone who's presenting with a locally advanced cervical cancer would need nodal interrogation.
Mm-hmm.
In our institution, it would have been radiographic. In other places, it's surgical evaluation. At MD Anderson and here, if there's nodal involvement detected, gross nodal involvement with a large pathologic node, the surgery is generally aborted, and we do chemotherapy radiation. In patients who have a completion surgery, including an extensive nodal dissection, the standard of care here is exactly what was given, which was chemotherapy with radiation using cisplatin.
And so the question that's being asked now about the optimal systemic management, is this about adjuvant chemotherapy?
Well, it sounds like, and you'll have to clarify, you had a post-treatment MRI showing an enlarged paraaortic lymph node. Is that correct? And how long was that before the detection? Because that, I mean, if it was right after chemoradiation, I would wonder if it was just reactive.
Right.
The MRI was performed like 2 months after chemoradiation.
Yeah, before you treat it with anything, I think we would all agree it should be biopsied and see what it was.
And the other thing is to figure out if it was inside or outside the radiated field, because if it's outside the radiated field, we call it, you know, a recurrence just outside the field. We actually re-radiate many times depending on where it is and the size.
I'm not hearing any calls for automatic further chemotherapy now.
No, I mean, I agree with what Don said, that I think it's important to try to make sure that there is documented disease there. I think if there is, there are data. There's one study from Neil Horowitz, now about 15 years old, looking at the risk of scaling node positivity in patients that have an aortic node that's positive. So I think it's important to try to sort out whether there's really disease in that node or not, because it obviously would. And what Kathleen said, I think, is also true, that whether it's in the radiated field or outside of it. Certainly, if it's in the radiated field and it's positive, I think she needs a metastatic workup, because I think the intent of treatment is going to be different from curative to potentially just palliative.
Go ahead.
Oh, I'm sorry, Don, but I really like the question you included about this of would there be any role for surgical rescue, because I think that's always a very it's an obscure English word, but a very tantalizing option. It's a very attractive option. If that is biopsied and turns out to be positive for malignancy, that paraortic node, that would suggest that it has progressed through chemotherapy, and I think that that is a very poor prognosis lesion that's much more appropriate in that case for palliative radiotherapy or chemotherapy, and I think most of us would favor local radiotherapy to that. Particularly with increasing use of minimally invasive surgery, people think it becomes sort of an attractive problem to go in and excise that node, but in the setting of disease that's progressed through chemotherapy, I think that's very unlikely to yield a long-term benefit for the patient.
So Tom, when you look down at the 1, 2, and 3 questions, can you just summarize for us what the optimal way forward is here?
Well, I guess, yeah, to summarize, and we'd be interested in your opinions on this, but I think that you know, systemic treatment, it's hard to know if this is immediately, first of all, we would certainly reinforce the idea that we'd like to see a biopsy of this, since it's immediately post-treatment and after radical surgery and radiotherapy, it could be reactive. If it is positive, then it's something that's progressed through chemotherapy. And if it's within the radiated field, as Kathleen says, it's progressed through both radiotherapy and chemotherapy. In that case, we'd pretty strongly recommend to move to palliative management. if it's outside of the radiated field, I think most of us would recommend regional or local radiotherapy to that lesion. I'd be interested in what Anusha's preference on that would be. And then again, I would just say that surgery is an interesting option, which I think is ultimately going to be unrewarding in this kind of setting.
I would agree.
What kind of therapy would you give?
I totally agree. I think you need to biopsy it, and you need to make sure it's whether it's inside or outside the field. So let's assume that it's positive and it's outside the field. We would treat with chemoradiation therapy and try to take the nodes to a more definitive dose, and then depending on the response, you could decide whether the patient needs systemic therapy or not. If it is inside the field, then palliative radiation therapy would be beneficial. But I 100% agree. You got to figure out. You have to have a biopsy. I think one thing we would have done before starting with chemo-RT would have been doing another CAT scan just to make sure that there wasn't anything, especially with a positive node, that we missed. So that would have been interesting to know. We would have had a pre-radiation CT, so it would have been interesting to know if there was any nodes that grew in between even the surgery and the radiation, and whether these are the nodes that grew. So that would have been an easy, I mean, we 100% would have done that. So that would have been something we would have had beforehand.
Okay.
I agree completely.
Is there anything left over? Is there what choice of palliative chemotherapy would go first?
Yeah, that's a difficult question. Say, okay, so if Anusha is assuming it's a localized recurrence or a recurrence in the periaortic, then I agree with her plan. If this was actually what it often is, which is a harbinger that she has metastatic disease, then we would start with systemic therapy. You know, the usual standard is a cisplatin-based regimen. Cisplatin, not carboplatin, cisplatin-based regimen using probably cisplatin and Taxol. Recognize that the Japanese do have a nice trial that shows if you had chemotherapy with radiation in the past, you can get away with using carboplatin and paclitaxel to best response. In the United States, the standard right now is cisplatin Taxol with the use of bevacizumab based on a randomized trial. You know, in certain select cases, we often will substitute carboplatin for the cisplatin in that regimen because of the toxicity concerns. But
Sorry. Okay. Myra, we've just found you on the camera. Are you ready with your case from Buenos Aires, Myra? Good morning. Can you unmute your microphone, Myra?
Yes.
Okay, now we can hear you. Thank you. Good morning, Myra. Thank you for getting through all your difficulties. Are you calm and relaxed and ready to present your case?
Sorry, I can't hear you well.
Myra, can you hear me now?
Yes.
Are you relaxed and ready to present your case, or would you like us to move on to someone else first and let you get...
No, I can present the case.
Okay, thank you. If you would go ahead from Buenos Aires, we'll start with the second case from Buenos Aires, and Myra Ferrer, who was a fellow with us, is going to present the case. Thank you, Myra, for joining. If you just wait a second, we'll put the slides up. And can everybody else mute their microphone, please, so we can hear Myra properly? Okay, Myra, we're ready for you when you're ready.
Okay. This is a case of 49-year-old woman with 4 pregnancies and 3 natural births. She has no family history of cancer, and she consulted in another hospital because of bleeding after sexual intercourse. They made a pap smear with the squamous carcinoma, and she had negative extension studies, the CT, colonoscopy, and urography. The diagnosis was squamous carcinoma E1B2. So the treatment plan in that center was neoadjuvant chemotherapy with paclitaxel and carboplatin for 3 cycles. After that, she had no response, and she was referred to our hospital for radiation therapy followed by brachytherapy. And after that, maybe 1 month after that, she was admitted in the hospital because of abdominal pain. And we made a CT pelvis, and she had parametrial infiltration. And the pelvic exam was exophytic lesions, bulky. So the diagnosis was disease progression again. The treatment plan in our hospital was chemotherapy with cisplatin, topotecan, and bevacizumab. And after 2 cycles of chemotherapy, she was admitted again in the hospital because of pain. And I want to say that the bevacizumab, she received just 1 doses because of the delay on the drug. So we made a CT scan, and I have the results today, and she has a lung progression. So the question in this case is about the neoadjuvant treatment in cervical cancer. For which stage is appropriate, and what is the response that you have? Because we have a lot of cases, but we don't have good response with the neoadjuvant treatment. And in this case that the patient is progressive, what is the new treatment options?
So when you say disease progression, what exactly do you mean?
When she has the diagnosis, she had no parametrial infiltration, and after the first chemotherapy she has, and now she has a lung progression. She has a pleural, a few nodes in the lungs.
Oh.
No, that's the second type. She's got progression twice. After cisplatin topotecan and bevacizumab, she's been found to have lung mets. So they got the CT result just today or yesterday.
And I want to say something because this is not the regular treatment that we have. We always start with cisplatin and radiotherapy, and the second line is carboplatin plus paclitaxel. But she came from another hospital already with that drugs, so we didn't have another option than this last treatment with topotecan and bevacizumab.
Yeah, so we don't really have a large experience doing neoadjuvant therapy here in the United States for cervical cancer. You know, if we extrapolate from breast, and Paul can correct me if I'm wrong, when you do neoadjuvant chemotherapy for breast cancer and there's a lack of progression, we will automatically or oftentimes will just take them to surgery rather than try medical therapy for a second or rather even a third time, just try to get the tumor out and then restart again. You know, I know the use of neoadjuvant chemotherapy is far more common in Latin America as well as Asia, but again, it's not something that we do routinely. Indications here and what I've seen is locally advanced cervical cancer, and then folks who are otherwise not candidates for surgery. I don't know, MD Anderson, you guys, Kathleen, are you guys using much in the way of neoadjuvant?
We're using almost none. The only time we start with chemo is if they have disease outside the pelvis. So if they have locally advanced disease, they can be radiation. But we have had a few cases where they present, you know, with a superclave node as well, something else, and we give them chemo. And then if they have a very dramatic response, we have gone back and radiated. But that's completely out of the box and not usual, but we don't. But I think it's a very interesting question. You know, Tom Randall and I have talked a lot about this for countries that don't have, you know, a lot of, you know, radiation therapy available or the wait is really long. I mean, I think that here we don't use it because we have access to such great radiation, but I think it's a really important question for us to answer, hopefully with studies with our partners in Latin America.
I think the limitation that I think we have here is largely what Don hit on earlier, which is that there are no randomized data. The data that we have are largely from retrospective meta-analyses, and I think the problem with those studies is that the comparison arm, which is radiation, is before the age of chemoradiation therapy, so it's very outdated. I think if you look at the studies, the largest meta-analysis includes about 21 studies, and it's a very heterogeneous group of chemotherapy regimens that were used to give the neoadjuvant treatment. So the studies that we have, the data that we have are problematic. But there is I think there's an EORTC 5599, and I think there's another study in India that hopefully will give us a better sense of what the right regimen is comparing to chemoradiation therapy.
There's also a study that's opened in Europe. England has opened it that's looking at neoadjuvant compared to chemo-RT, and they're actually accruing right now as well.
Is that the interlace study?
Yes, the interlace study, exactly.
So we're making a note of all these studies, and we're going to distribute them to all the viewers and participants after this tumor board. We'll send a link to people to be able to look at these studies.
But Mayra, you know, in terms of your question about the activity of carboplatin Taxol, it's supposed to be really good. 70 to 80% is what's reported in the literature in terms of response rates. So, question of, why she didn't respond is a really interesting one, but it's rather uncommon, I think, that patients don't respond to carbo and Taxol. And in fact, to see frank progression on carboplatin and Taxol is quite worrisome for a squamous cell.
I agree, and I think it means that it's a terrible case, and I don't think that you should have a lot of feeling that anything was mismanaged in this case. It's highly unusual for a cancer to be this aggressive. Presenting locally advanced like this, there was a very high risk that there was microscopic metastatic disease that would not have been addressed by radical surgery, and that disease was chemo-resistant. And furthermore, generally, the molecular changes that make something chemotherapy resistant also make it radiotherapy resistant, as we see in this case. And so I think the cards were stacked against us with this case, and I'm not sure that a different approach from the start or during her course would have made a difference from the fundamental things we see biologically about this cancer.
There was a nice review that was just published just this year on neoadjuvant chemotherapy. I can pull it for Paul, and he can send it out to you if you'd like.
Yeah, that would be great. So it sounds like, am I right in concluding that in the U.S., the reason neoadjuvant chemotherapy has not been so well explored is because of the accessibility of radiation. So radiation chemo is more usual.
Yeah. Al Cousins from Canada and I tried to propose a neoadjuvant chemotherapy trial. It was not supported by the steering committee. And I think it's because, for the exact reason, that chemoradiation is so widely available, and for a large proportion of folks, we can cure people. So there just wasn't much appetite, although Anuja was clearly in favor of doing the trial.
So the South Americans can look forward to data from, I think I heard 3 ongoing trials.
Yep.
At least 3 ongoing clinical trials, Myra, will answer the question about chemoradiation versus a neoadjuvant chemo alone. And so with the data on there today, but Don Dijon is going to give us a meta-analysis publication of the data that is available in the literature, and we will circulate it after this tumor board. So thank you very much for that case. And because
I just have one question. Do you have any treatment for this patient?
Ask the question again, please.
If you have any idea of the new treatment for this patient now that she's progressed again.
Okay, just hang on.
Anuja?
I don't think I don't think there's a good answer for this. I think, it sounds like she's getting cis topo, right?
Cis topo progression.
Yeah, she's getting
cis topo bad progression.
Yeah. So I think you gave her kind of the best, in my mind, the best chance with cis topo and Avastin. And I don't think we don't have good chemotherapy at this point. We would offer a single agent chemotherapy for palliation, but that's about it. There's nothing good to offer her.
Yeah, so, the only treatments that probably have data that you could use is Alimta or Pemetrexed has some data. Although, again, a lot of our trials that were done were really an older population that didn't see paclitaxel before. But Alimta is one that we use, and Vinorelbine. One of our phase 1 trialists is going to open a trial using nivolumab, which is an immune checkpoint inhibitor. And that's fairly promising, particularly for virally mediated malignancies. So that's going to be an option. Hopefully that will be open here in the next few months. And they have an entire cohort for cervix, vulva, vaginal cancers, because all of those are HPV mediated. So there's some preliminary data that shows these checkpoint inhibitors are important for viral cancers. And if you are able to try to enroll her in a trial using an immune checkpoint inhibitor, might be her best shot.
Okay.
I also just want to add, sorry, go ahead.
Just a reality check. Those drugs are like $1 gazillion, right?
I said clinical trial, not off-label.
Right. Okay, I agree. But just, when someone progresses through primary treatment with Taxol and carboplatin, I know we're all oncologists and we're forever hopeful, but I think just the reality of the situation is that supportive care has been shown to work probably as well as all these chemo agents. And clearly, we could try existing drugs like gemcitabine or navalbine, but the probability of these working are extremely, extremely low. So I think here in Houston, we would send this patient obviously or offer this patient a clinical trial, phase 1 trial, and a lot of times with something that you mentioned, Don, which I think are great options for the future. But I think, realistically, I think we just have to realize that the prognosis for this patient is extremely poor, and in the absence of the possibility of a clinical trial, that really to consider supportive care as our first recommendation.
Right.
Just a small comment. One is to make sure that the pathology has been interpreted correctly. It's just I agree with Tom that it's a very unusual presentation and progression of disease for your typical squamous cell. And the other thing is if the patient has been tested for HIV, just to make sure that she doesn't have underlying.
Yes, we already did it, and she's negative.
Negative, okay.
And I just make
It's all rare tumors with me. That's what Tom is saying.
and I'd like to make one commitment and comment that I've been itching to involve our very advanced palliative care services here at MGH for a tumor board, and we may be able to combine the cervix and breast cancer groups together, and we have a master end-of-life palliative care, supportive care tumor board, and I think this is an area of sort of great importance to doctors in South America, so we will be doing that this coming year in 2016 for sure. But anyway, thank you very much, Myra. You've done everything possible for this patient, we think. So thank you for presenting. Yeah. And Zaida Morenti is from Lima, Peru, and she's ready. I think, Zaida, are you ready to present your case?
Yes, good morning.
Good morning. Good morning. Just a second to show. We're ready for you. Ready, Zaida. Can everybody else be quiet, please, while Zaida presents her case? Thank you. Go ahead, Zaida. We're listening.
Okay, this is a case about a 43-year-old woman with the following background. Menarche at 12 years old, 3 sexual partners, first pregnancy at 17 years old, and no family history of cancer. On September 2006, attended the outpatient clinic with 1 year history of spontaneous bleeding, no other symptoms. The gynecological examination finding were a 6 centimeter exophytic bleeding cervical mass with left parametrial involvement, and the cervical biopsy informed moderately differentiated ulcerated squamous cell carcinoma. The patient was diagnosed with stage 2B cervical cancer, and she received radiation therapy in pelvic fields on September 2006 and underwent observation. On December 2008, attended the outpatient clinic with vaginal nodules and bleeding, and she started cisplatin plus paclitaxel times 6 until June 2009 with negative PAP control, and then she underwent observation. On November 2013, presents hematuria, and in the abdominal CT, we found a 6 centimeter para-aortic and 4 centimeter iliac lymphadenopathy plus 5 centimeter adrenal lesion. With the results, she started carboplatin plus paclitaxel times 6 until June 2014, with chest and abdominal CT negative on October 2014. The last control was on August 2015, and the chest CT and abdominal CT was negative. Okay, the first question, what are the treatment options for relapse in this type of patients?
Well, in terms of treating her now, is that the question? Because it sounds like she doesn't have evidence of measurable disease right now, right?
Yes, she's in negative.
Right. Yeah, I mean, I wouldn't start on anything right now. You've done. I mean, she's responded quite remarkably, actually, to your chemotherapy as compared to the other case where you've been able to put her back in remission. You know, going on Kathleen's points, this is not a curative situation, so there's no sense pushing chemotherapy without an indication. I would just follow her symptomatically and treat if there was evidence of tumor regrowth. As far as we know, there's no treatment-free interval to help guide whether or not you can retreat with platinum, but I would be tempted to do it. If she went 12 or even 18 months without a recurrence, I'd be tempted to give her the same regimen again. Chances are likely she will not do that, in which case it's the same discussion we had before in terms of options, you know, of treatment versus palliative care versus a clinical trial.
Any other comments? Kathleen, do you want to say anything from MD Anderson?
Yeah, we would agree with just watching, and then if she recurs, if it's long enough out, to retreat with the same regimen. One question we had was, did she get brachytherapy originally with her external beam radiation?
Yes.
Okay. And did the radiation field extend to the parodic lymph nodes, or was it was only the pelvis?
Pelvis.
Pelvis. Okay.
And was the vaginal nodule in the original field? Or was it outside the field?
Yes.
It was in the field. Because again, similar to the parodic lymph node story, if people recur below the field or outside the field, then sometimes we'll re-radiate or that area. But it sounds like she had other disease at that time, so we would have done the same thing with carboplatin and Taxol. And here in the U.S., we would add Avastin to that as well. So we would give carboplatin, Taxol, as well as bevacizumab.
Yeah.
But obviously, it's a very expensive
But she's done well.
But she did really well.
Yeah.
I think the other option would have been in 2008 when she had the first recurrence. If she only had like a vaginal nodule and it was just the only side of metastasis or the recurrence, I mean, here we could have offered her pelvic exenteration.
Yeah, right.
That would have been like probably the most definitive treatment for her.
Yeah, sorry, I missed that actually. If her recurrence was only local, so the first question is that vaginal nodule in the field? And if it were in the previously radiated field, then we would offer an exoneration. If that were outside the field, then we would either surgically remove it and or potentially radiate the area as well. But if it's an in-field recurrence and there's no metastatic disease, then we would have done an exoneration as well. Though it probably would have been the wrong treatment if a year later she developed parodic disease.
Exactly.
No, but it was,
Dr. Moranti, have we answered your questions?
it was 5 years later.
It was 5 years.
Yes, thank you.
Do you have any follow-up questions or comments for the panel?
We should have been cured.
No more comments.
You've been satisfied?
Yes, we have a question here. What is the opinion of the panel about the re-challenge with carboplatin?
So, go ahead, there you go.
No, Don is
Don, what was the question?
re-challenge with carboplatin.
I think it would depend on how long her remission lasts at this point. There's really nothing to help guide at what point does carboplatin make sense. I think probably rule of thumb, and I think this is open to opinion only. If she went a year out before her relapse, I would probably do a carboplatin and Taxol regimen. And what Kathleen was saying, I think, is also valid. If you had access to Avastin, that probably would be the opportunity to use it. And it also depends on, I think, with such a patient, I think you'd have all of the therapeutic options available. So if she had a locally or an isolated recurrence lesion, then I would be very tempted to get one of our surgeons to comment on whether or not this was something that could be resected. Or I would get my radiation oncologist colleagues involved to say, what do you think about radiation therapy? But in my eyes, it would be nice to reserve medical therapy for distant or widespread metastatic disease rather than to treat locally recurrent disease, particularly the third or fourth time.
Yeah. I think it's a difference rather with a parodic node and iliac node. An adrenal lesion, that's too much.
Yeah, I think it would depend. I mean, if it was a locally,
if it was just a locally parodic,
I should say isolated. And
no, an isolated parodic.
I agree with Dawn. If it was isolated again, and if it came back like to the parodic nodes, I would probably radiate. I mean, she's 5 or 6 years out. So Dawn, I totally agree with you. If it's an isolated parodic or a superclave lesion, I would probably radiate at that time. 100%.
Yeah, I mean, not everything needs. I guess the point is, not everything needs systemic therapy. For someone who's acting, remarkably outside of what you'd expect, I think I'd want all options to be available.
What, you wanted to ask a question?
I just was thinking that as this patient has had a pretty long intervals free of disease and seems to be a really good responder, is there any factor that we could use like a predictive here to see which patients are going to perform like this, or like, I don't know, to tailor therapy for them?
Yeah, right now, I think the biology of cervical cancer, I don't even think we have started to really explore it. There's a really interesting study that's ongoing at the NCI that's trying to identify immunotherapy candidates more precisely, but they're looking at growing patients' lymphocytes, activating their T cells and reinfusing it. And if you look at even something like that, some patients respond beautifully, like durable responses that go on for years without therapy. But trying to predict who those women will be is still ongoing. I mean, I've had patients who wanted a complete response on navalbine, which is why I'm still quite a fan of the drug, but it's anecdotal. I mean, the literature says it doesn't work. But you'll see 1 or 2 patients who it responds beautifully to. Don't laugh at me, Kathleen. I have seen it.
We have too, and we're just joking about how we treat patients based on our N of 1 all the time, or 3.
Yeah.
Are there any other comments from the panel? We've had a very good discussion. Thank you very much. I think we can draw to a close. I will ask Don and others on the panel to send us references, the manuscripts and the clinical trials, and then we'll circulate them all to everybody as promised. And I do promise to hold a palliative care tumor board in the near future, and I'd like to thank everybody for attending. Thank you very, very much. It was great. Thank you for overcoming your technical problems in Buenos Aires and in Peru. Thank you very much.
Thank you. Bye.
Bye now.
Thank you.
Bye.